This program examines knee and hip osteoarthritis as well as related conditions that may stem from or contribute to joint pain and mobility issues. It documents the assessment and treatment procedures used in manual physical therapy.
Well, where I live in California, I've seen numerous physical therapists and orthopedic doctors, and I'm getting nowhere with them. I know intuitively and instinctively that their diagnoses are not correct.
I want you to do just that much.
Ow!
Back down. Manual therapy is great. I'm not fixing you. The fix is changing the way we're doing things.
It's so tricky.
And this is an issue that is vastly overlooked throughout physical therapy as a whole. I don't care if you're using a lot of muscle. I care that we're just doing it right.
It's a serious issue, I think, for the country, you know. They push surgery, something I don't want to do.
We need to be able to truly identify any possible factor that can contribute to their pain experience.
My name is Patricia Rourke. I'm 75 years old. I'm basically retired. I hate to say it, but due to my current disabilities, I don't really have an active life. I mean, I live alone at home and, you know, I do cooking, shopping, things like that, but I don't do much beyond that right now because I'm not driving yet.
Okay, so you can just take a seat on the bench right here.
For 2 years, Pat has lived with unexplained knee pain, a sharp, stubborn ache on the inside of her joint that no one seemed able to diagnose. She's seen multiple doctors and physical therapists, but nothing helped. The only answer she kept hearing was, maybe it's time for a knee replacement. But something didn't sit right with Pat, so she came to El Paso Manual Physical Therapy looking not just for relief, but for answers.
All of a sudden, out of the blue, this area here didn't swell. I mean, nothing out of the ordinary, but I got a horrific pain right in here.
I will get a pillow set up and I'll have you just take a seat here for now.
When addressing knee pain, Dr. Kendall typically begins by assessing the quad muscles, the position and mobility of the kneecap, and any areas that are especially tight or tender. These can often reveal underlying movement restrictions that contribute to the problem.
Now your kneecap should move a decent amount. Now I'm not working too hard to try to move it, but generally speaking, I shouldn't have to work very hard to get it to move, and that is very, very stiff.
That's arthritis then?
That's part
Okay.
of the arthritis, absolutely. The patient's problem is she was having some pain on the inside of her knee, just below the joint line of the knee. With this in the past, she's been diagnosed with knee arthritis, so everybody's always assumed she had knee arthritis and that was her only issue. What we determined was that it was actually a saphenous nerve issue that was likely coming from a pelvic innominate, so her pelvis was rotated, and along with that she also had some pretty extreme lumbar lordosis. So with that, there's multiple regions that could have been causing some of her pain. One thing we do have to take into consideration that I haven't checked yet is you've had a hip surgery, you've had a hip replacement. It is possible that after the hip replacement surgery, this leg actually is longer. So we have to consider that as a possibility, but I do want to check your pelvis here in a minute as well. I just want to see for now what's tight, what's not. So let's roll to the other side. Yep. So a little bit higher on your left side, which means, yes, that left side is either rotated back, right side could be rotated forward, or both. Oftentimes we see a little bit of both. So let's treat it. A common misconception with something like knee pain, for instance, is a lot of people will find on an x-ray that there is, definitive knee arthritis. And so because you have knee pain, It's from your knee arthritis. And most of the time, that's not actually true. If we only look at a single area because they have knee pain, I look at their knee. If all we're doing is looking at that region, we're not doing the patient any justice, because knee pain can come all the way up from your upper back, even in your thoracic spine. We need to be able to truly identify any possible factor that can contribute to their pain experience. Because if we leave some of that out, we will leave them with some pain, and they will end up going down the rabbit hole of never being able to truly get back to normal.
I won't know how the pain is until I walk around, because I don't have it laying or sitting down. So I have to do that. Um, yeah, it is definitely better, like way, way better. But also, as you walk around, it can come back. This is not a situation that's going to go away right away. I know that. This is going to take time.
The first thing we found to be important, you have a pelvic complex rotation. Okay. That is going to be a likely contributor to your pain, for sure. Your femoral nerve comes out the front here, turns into the saphenous nerve, and with that, we can be, if we're rotated either direction, we can be creating some friction on the nerve there. So we need to really be cautious of having too much of a rotation.
And that's part of the cause of this pain down there.
Part of that stiffness and tightness that you likely feel in the left hip up in this region is actually from that. It's that joint is not moving quite the same as the other one. It's a little bit stuck, and we just need to get it to move a little better. Okay. Then we also found that working on your low back, your lumbar spine, improves your saphenous nerve problems. So then...
Wait a minute. Working on the lumbar spine improves the esophagus nerve.
The saphenous nerve.
Yeah. Esophagus.
And with that, that tells us that it's not just a problem with that nerve. Does that make sense?
Yeah.
Okay.
I've probably seen 3 or 4 physical therapists and 2 or 3 orthopedic doctors, surgeons, and very frankly, I didn't feel they knew what they were doing. I mean, I'm not trying to put anyone down. I think they just know the standard medical answers to these types of pains. They push surgery, which is something I don't want to do, and they don't dig deeper. I think a lot of the physical therapists are trained to deal with people who just had a recent injury or a recent surgery and to help them recoup, but they are not trained and knowledgeable in helping someone, say, that's had a muscle problem for 20 years and wants to get rid of it and doesn't want to go for surgery. I haven't found anyone that is good at that.
Success for a client like this who's been dealing with these issues for so long, these sorts of things we need to look at in terms of small wins. It is a minor improvement in pain in the short term. It is, I can walk a little bit better or straighter in the short term. Long-term success, it's very easy to look at that. And of course, I want to be pain-free. I want to be able to walk and hike and do all these other things that I used to be able to do. But if our goals are so long-term, we tend to get a little discouraged because of that. So when we start basing success, we have to look at it in more of a short-term approach. Slightly been able to improve the way I walk. I've slightly been able to improve my pain. And when that consistently happens over the span of weeks, we get to a point where you realize, looking back to the beginning, that we've made such a massive increase, and it was a lot less daunting of a task because you were just looking for the next step rather than the end goal.
It's a situation where I guess over years, over time, you don't use certain muscles, you get weak. So I have a multifaceted problem of abdominals, lumbar, pelvic issues, and the saphenous nerve. I hope he will set me up with a program where I will know exactly what I have to do every day on physical therapy, to improve, and what the goals are, after that. Today I think we talk more about the physical situation, and then after that, I hope we're just doing the physical therapy that I'm going to need to do at home.
At her second visit, Dr. Kendall focused on Pat's posture and core control, working on her spinal alignment and showing her how to actually engage the right muscles during abdominal exercises.
When you were doing the abdominal exercises, just to check, what position were you doing them in?
I was laying on my back.
Okay.
With my feet extended, just like I am
like
now.
This. Okay. This, I think, is too hard for you. This is the progression of the exercise. We try to make it as easy as possible in the beginning because we want to make sure you're doing it correctly. I don't care if you're using a lot of muscle. I care that we're just doing it right. So in this position, we have maximally stretched your abdominals because your hips have rotated in a way that stretches this region. So you are making it as hard as possible for your lower abdominals especially to work right now. So when we do it, especially to start off with, we're going to want the knees bent. And
both knees?
Both knees. And I think even going back to what we did the first session, we want something propping your torso up a little bit too. That way we shorten from both ends, and then that makes it a lot easier to use the abdominals. I'll have you go ahead and sit up now. What I want to go over now, we still want to do those abdominal exercises, as I mentioned.
Can I try one or two so you
Yes.
verify now that I'm doing it correctly?
Yes.
Because that's important.
Okay. And just tuck your chin forward for me a little. Perfect. Go ahead and push down for me. And relax. Okay. So, I want you to picture this portion of your stomach. I want you to suck it up into your chest.
Okay.
Okay. It is a very large tendency for us as humans to get in a routine, to find a way to do things with minimal effort. And because of that, we end up being very task-oriented. But the issue with that task-oriented approach is that we're not caring about what we're doing. We need to care more about what muscles are controlling the motion. So again, we're going to take this, suck it up into the chest, and relax. Okay? We did get a little bit of activity here, and that's what we have to be cautious of. We don't want these muscles firing because they're going to try to help with that, and that's not going to help us at all. We don't need that. The tendency for most people is to do these exercises, but then they recruit other muscles like your quads, your psoas, which are your hip flexors. That is why we can't think of it as a task of doing sit-ups. We have to think of it as a task of, I need to activate my lower abdominals. We want to use the quads as minimal as we can. In the beginning, you're not going to be able to completely cut them out, so don't worry too much. But I want to make sure that I emphasize eventually we want you to not use these very much at all with this specific exercise. For this individual specifically, the largest challenges she's going to face are related more so to her ability to follow the exercises correctly. Something she learned in our session is that she's been doing the correct exercise for years. But she's done it in a way that was incorrect. She's done it in a way that she's using the wrong muscles. And in doing so, she was actually feeding more into the problem rather than actually getting better. And this is an issue that is vastly overlooked throughout physical therapy as a whole. And if we can make sure that we're very, very strict in the way that we're doing these exercises, we can actually start to improve the way that the muscles activate around the joint. And then with that, we will finally be able to get better. But if we're doing the correct exercises, even if the exercise is absolutely the right exercise, if we're doing it the wrong way, then it's not the right exercise.
On her final day, Pat worked with Dr. Kendall to fine-tune her form. With just a few corrections, She started learning how to activate the right muscles and build better movement patterns.
You want to start with just a staggered stance like this, and you want your weight on your back leg. This is the leg that controls you. So if I'm standing in this position, both of them are squeezing and keeping me stable, balanced. If I'm here, my right glute is going to be a whole lot stronger. It's going to be better capable of controlling everything I do. If I try to squeeze my left glute in this position, it's a lot weaker because it's a little more stretched. So in this position, if I want to shift my weight forward, I can squeeze my right glute, and all of a sudden it pushes me forward. That's how we take one singular simple step. So as I do that, I have now progressed forward. Then all I have to do is swing that leg forward.
And that heel first.
Heel toe, yeah.
Yeah.
We want to utilize that rocker of our foot. Our foot should rock forward, and that carries our momentum with us better. Okay. So as I do that, I squeeze that right glute, it pushes me forward, and then I pick that leg up. Once that leg's up and off the ground, now my left glute takes over. That is how we get into walking. Even doing that is going to be really difficult. So I generally recommend we start a single step at a time. So isolate one leg, and we step, and we step, and we step. Then, of course, alternate. Do the other side. Make sure you're getting really good at using both legs. And again, you always want to analyze your body. Where is it? Is my body weight coming forward, or is it on my back leg? So it's easy as you're doing this to start to lean forward. And we want to make sure we analyze. And we stay upright. Does all that make sense?
Yeah.
Okay. So questions on that?
No, just
No?
that I know it's going to take a while for it to...
But you see, just what he's done so far, I can see your gait has changed.
Good.
And you're not dragging your foot as much. You're not really realizing it because you're not analyzing it. But from someone sitting there watching you or walking behind you, they can see the gait difference.
That's awesome. So now we're going to go to the hardest exercise that most people think is simple. That's the clamshell.
Yeah, it seems so simple.
So I'll have you lay on your side.
Next, Dr. Kendall had Pat try the clamshell, an exercise she's done before, but today he watched closely to check her form and make sure the right muscles were doing the work.
Did you want me to show you how I did it, or?
Let me see how you did it first.
All right.
And I want to feel some muscles as you go. So go ahead.
If I remember, you used to help me with this. One leg is slightly forward, right?
Mm-hmm.
A little bit, like this.
Yes.
All right.
Oof. Okay. So that was wrong.
All right.
Seems so simple, right?
Yeah.
So I want you to, I'm going to take your hand. I'm going to put it right here. So go ahead and do it again. Feel that right there? That massive muscle that kicks up into your hand? That's your TFL. That is a really strong muscle on you. It's not supposed to be a massive muscle. It is mostly a stabilizer for us. And we're not using it as a stabilizer at this point. We're using it to force motion in the leg. And likely, when you're walking, when you're doing anything active with these things, you are using these muscles way too much. So they are actually becoming very dominant. So something else you can do to make it a little easier to target your glutes is actually put your right shoulder behind your torso. We want this shoulder a lot further back. Okay, and roll forward a little bit. And even here, we're going to come forward just a little more. Okay, now I'm going to stabilize you, just for now at least. Okay, and I'm going to feel that gluteus medius because I want to know if it's working or not.
All right, so you want me to...
Okay, I want you to do just that much. Back down.
Ooh.
Felt that muscle, right?
Let me see. You're not pressing?
Nope,
He's just got his hands resting on
just
you,
resting. Go ahead and do
feeling
it
the
again.
muscles.
Oh my God.
For our purposes, the reason I only want you moving that much is because the gluteus medius in that position that we were just in is really good at initiating the motion. But the further in the motion we go, the more likely it is that that TFL is going to take over. As soon as that TFL takes over, we lost. We don't need to do the task. We need to do the muscular activation. I want you to monitor this muscle here, and then of course, slide around to the front, that muscle there.
That's the tensor muscle, yeah.
Yes, it is. So, if we're monitoring both those muscles, we're giving ourselves a complete idea of what we're using to accomplish this exercise. If you feel that TFL right there kick on and be really active at a certain point, take a break. Likely either you're just trying to go too far, or it's very possible your gluteus medius is becoming fatigued, and then you're going to try to compensate and use other muscles to accomplish the task. We don't need to get to the point past fatigue. Getting to fatigue is really good. We don't need to go past it.
Mm-hmm. It's going to be a little tricky learning some of this stuff, but I think I'm in good hands. I've been to numerous doctors and physical therapists, and no one was able to identify what this pain was. And I learned other things, just a whole lot of things about my body that I didn't know before. And now today I'm seeing new ways of doing an exercise that I've been doing for a year, and I'm just finding out I've been doing it incorrectly, and I had no idea.
A little bit of rotation in your pelvis. That definitely seems to be a contributor to your saphenous nerve involvement. With that saphenous nerve, that is something that we're going to want to continue to work on, is your pelvic rotations. Okay.
That's mainly causing it, you think?
I think so. I think that, and maybe a little bit your back as well. In these instances, we have to assume that there is a contributing factor in both regions.
Right.
With that, of course, the abdominals are going to be a massive help.
Pat still has work ahead, but in just 3 sessions, she gained something she hadn't found in years: clarity, a plan, and confidence in her next steps. Now equipped with a personalized program and a better understanding of her body, she's leaving El Paso with more than short-term relief.
I felt relief because for 2 years I've been trying to find out what this pain is. And I just felt relief, like now I finally know. And I know I don't need a knee replacement either. You know, that's very important to me because I don't want to go for a surgery. So, I mean, it's just been incredible, the amount of things I've learned. I think El Paso Manual Physical Therapy is phenomenal. It makes me want to move to El Paso from California so I could just work with these people. They're great. I just wish there were more physical therapists available like this, and there aren't very many. It's a serious issue, I think, for the country, you know.